Hey guys, welcome back to my channel. Today I wanted to make a video on how to do just a quick head to toe assessment. And I say quick because while I'm going in depth, I'm not like going like deep in depth. Like I'm doing enough to know if there's a problem. Like I can catch an issue. So usually what I'll do, because you probably heard this in nursing school, but you're assessing your patient right away. Like as soon as you go in and you immediately looking at them, you're already assessing. You're looking at how they look. Do they look clean? Do they look disheveled? Do they stink? Do they look well kept? Do they seem confused? Do they look in distress? So you're already assessing immediately as soon as you start looking at them. So you're just doing like a quick once over anyway. Like as soon as you go in, you're looking, you're listening to how they sound when they talk. Um, how does their breathing sound when they talk? Like are they, seem kind of short of breath? Do they seem like a little slow? Like they may have like a learning disability. So is there a language barrier? So you're already picking up information straight away as soon as you go in and say hi. So what I do is I'll usually go in and introduce myself, and I will just start asking neurological type questions. They don't even know that I'm doing it, but I'll be like, hey, so your name, what's your name? And they'll say their name, and I'll say, what's your birthday? How old are you? So already I'm seeing if they are alert and oriented. Do they know who they are? Do they know their age? Um, then I will go into, okay, so what month is it? Do you know who our president is? Do you know where you are right now? Do you know why you're here? Is it daytime or nighttime? And sometimes those questions could be a little hard, especially if the patient, was in the ICU, or they've been out of it for a while. Sometimes it's kind of hard to know whether or not it's day or night. So that one I'm not so tough with. I won't judge them too bad. But if they don't know who the president is, or like the month, and we're like in the middle of the month or something, and they don't know that, or they can't remember their own birthday, then that there's some deficit there. If they have a head injury, I will like look at the injury on their head, or if they fell and had hit their head, I'll kind of touch around the head for tender spots, for soft spots, for lumps, bumps, things like that. But if they're not there for that and they didn't fall or anything, I'm not like checking all over their head. I'll give their head like a quick once over to see, just checking for like bed bugs or anything, like things like that. But I really don't go digging into people's hair or anything. um then while I am, because usually once I'm going in there, I'm taking their vitals while I'm doing the assessment. So while I'm like getting all the equipment set up, the blood pressure cuff and all that, I will start asking them questions. I'll say, have you been having any shortness of breath, any chest pain, any numbness or tingling to your fingers or toes? Okay, so that's telling me a lot right there. Potential heart attack, or breathing issues, oxygenation issues, numbness and tingling, circulation issues. So I'll ask them that. I will check their pupils. I'll take my little pen light, check their pupils, see if they're equal reactive. Um, if there's perla. Then I will usually ask them, like, if I don't see it, I'll say, do you wear dentures? Do you have dentures? Do you wear glasses? Any hearing aids? I'll ask that stuff, because sometimes they have it, but it's just not here at the hospital. So I like to do that. While they're talking, I do like to kind of look in their mouth to see, just check the whole teeth situation. Is their teeth missing? Are there cavities or anything, any decay in the mouth? I'll look for that. And again, if they're not here for like a throat issue or a mouth issue, if they don't have like like an infection of the mouth or something, I'm usually not scanning all inside the mouth or down the throat or anything. Usually not doing that. Next is I will listen to lung sounds. So I'll usually have them sit up if they can, and I will listen to lung sounds. You listen wherever you listen at on one side, you want to listen at to the other side. Go down, listen, go down, listen like that. Um, and I will listen to their back as well. If I'm able to, if they're able to get up or roll over, I'll listen to lung sounds in the back. Um, then I will listen to the heart. So I'll listen to see if I can hear a heart murmur. Also, while I'm listening to their heart uh, rhythm, the heart sounds, I will touch one of their radio pulses, and I will see if it beats at the same time or if it's irregular. Is there some AFib going on or something, like you're beating a lot up here and only a few are coming down, down on your radio pulses. So I'll see if those are regular or not. The next thing I will do, since I'm already here, is I'll just bring the stethoscope a little bit lower, and I will ask them, have you been passing gas? When was your last bowel movement? Have you been having any problems having a bowel movement? Then I will start listening to their bowel sounds, seeing if I can hear any gurgling. They say if you don't hear anything after 5 minutes, then that is what's considered hypoactive. So just because it may take 2 or 3 minutes to hear a sound, that's not considered hypo. I think it's like more than like 5 minutes or something. I'm not sure. It could be 10. I'm not sure, but I know it's a while. Like you have to stand there and listen before you could call it hypoactive. So then I will ask them, since I'm talking about that whole area, I'll go ahead and ask them their voiding characteristics. So if there's no catheter, I'll ask, how have you urinated? Any burning, irritation at all when you've urinated? Do you feel like everything's completely coming out? Are you dribbling? If they have a catheter, I would check the site, look for any like skin irritation, like redness or swelling, any discharge. Make sure the area is clean. Make sure the catheter is clean. Make sure that it's connected to the stat lock on their leg. It's not moving or tugging or anything. Check the the tubing to make sure it's not kinked, to make sure the urine is having, being able to go down without, being blocked or kinked off. I will make sure that the urinary, container or the bag is not like hanging on the floor. Make sure it's up but below the level of heart, on a non-moving part of the bed. Then I will, come back up and I will ask them to squeeze my hands. Before I used to have them like squeeze my whole hand, but now I just have them squeeze like 2 fingers. Sometimes they squeeze and it really like hurts. So now I just have them squeeze my hand, and I will cross my hand over like that. So then that way, if they are squeezing my right hand, I know that that's their right hand and left to left. So I'll cross my hands like this, and I'll have them squeeze my fingers to check for hand grasp. Is it strong, moderate, weak, absent? Then once they squeeze my hand, then I will take their finger, their thumb, or their index finger or whatever, and just press down on the nail bed and see how fast the blood fills back up. Try to make sure that it's less than 3 seconds. That's what we want. For women with nail polish, that makes it very difficult, but you can like check their toes or their kneecaps, or like right above their kneecap. That's another good place to check for capillary refill. Then once I do that, I will, like as I'm moving down, I will kind of like squeeze the thighs a little bit because I'm checking for edema, like are they swollen up in the legs. So I'm going down, squeezing the lower legs now. I will again like press above that kneecap and check for capillary refill there. I will ask them to do flexor plantar with their feet. So I want them to like a dorsal fin, like point your toes up and then, point them out like a ballerina, just to see if they're able, to house their mobility. With that, um, I will check. I don't really check like the popliteal pulse, like the pulse behind the kneecap. I don't really do that. I check like the posterior tibial. Um, like by your inner ankle. I'll check there for a pulse, and I'll check like on the top of the foot. Um, I'll check that pulse up there to see, on the top of the foot. Uh, check the pulses there. Then I will look for any, like, if they have like surgical sites or something. I'll look at that. If I can, most of them are like covered up with bandages, so I just try to make sure that it's clean, it's dry, it's intact. It's not like loose or coming off or anything. If it's like a fresh dressing, like where I can't change it yet, the surgeon has to change it, I'll just, and I see some drainage, sometimes I'll just mark it with like a permanent marker. I'll make a circle around the drainage area just to see, when I check it later, to see if it's continuing to drain out or if it's staying at that same amount. I'll check any wounds that they may have. If they're open to air, I'll change any dressings at that time if I need to, if they're dirty, soil coming off, or if it's just time, if it's scheduled to do wound care, I'll do that. Another thing I do is I will check their IV access. If nothing, well, checking it, the first thing you're doing is you're looking at it. You're looking to see, does it look irritated? Does it look infected? Is it red, swollen? Is it tender? Is it leaking? Is there like a bunch of dried, bloody drainage around it? So yeah, if it's infusing, I'll pretty much just leave it alone. Just go ahead and let it infuse. I will, tap around the area, ask them, does it feel okay? You having any pain there? If it's not infusing and it's capped off, then I will uncap it, unlock it, get a flush, a syringe flush, draw back a little, push back up, get rid of that air bubble, and then I will flush the IV, the INT. I will flush it. I will draw back to see if I can get any blood return, and then just, continue to flush. Then I will lock it back and cap it back off. So yes, just making sure that the IV access is still good. And then I will usually ask them, like, are you having any pain at all? I know they say like don't ask, but I still ask sometimes for the most part, like, are you having any pain, discomfort, or, blah, blah, if they need anything for that. So, yeah, that's usually how I do, like, my little quick head to toe. And usually, like, those questions are what they're looking for when you are charting, when you go to chart. If you've done all this that I just said, that pretty much gives you your, like, what you need to chart your assessment. So, and sometimes in certain areas you may have to go more in depth. If they had like surgery on a certain arm or something, you need to check like neurological function of that arm or something. You may have to do more things. Or if they're like a stroke patient, you may have to do, like a more in-depth neuro check on them. But yeah, so yeah, for me, for the most part, for like your general med surg type patient, this is more than enough. Probably too much for some people, but yeah, this should be good enough for your charting. So I hope you enjoyed the video. Let me know if I missed anything or if you do anything extra. And until next time, bye.